trade secret. Whoever was doing the research wanted to hold their information, keep it so they could generate more research. And what's happened with this is now it's public, so anybody can grab into this research and then generate more hypotheses, generate more drugs, and expand the development of drugs. Want to comment about, what relapse is? Because I think the concept of relapse has really changed, and some of the patients on Compass have relapsed, but they haven't relapsed in what we would consider a traditional relapse, because we don't let people get into that same system. Dr. Cole?
So we now know that, oh, thank goodness, since I was a young doctor with hair, that we have changed the way that we look at relapse. Relapse used to be that we would wait until people develop symptoms or had recurrent symptoms of the disease. And part of the reason we would wait so long is that the treatments that we had were so limited that sometimes it was better to just wait for the symptoms to happen before we actually treated them. Now, one thing that we do is we look at the protein level. And so, there are a couple really important things to know as a myeloma patient and having being a caregiver for someone with myeloma is knowing the M protein of myeloma, or monoclonal protein. That protein level tells you exactly, without redoing the bone marrow biopsy, which I'm sure that nobody really wants to jump up and down about to volunteer for, that instead of doing the bone marrow biopsy to count the number of plasma cells, that you can determine the amount of plasma cells in the body by checking the protein level. So when people come in with newly diagnosed myeloma, their protein levels are high, and we do the bone marrow and find out that the number of plasma cells are high. And as they respond to the treatment, the protein level goes down, and the number of plasma cells in the bone marrow goes down. And in the same venue, that when the disease comes back, that you'll start seeing the protein level rise. And it will, and left unguarded, the protein level could rise to the point where the person begins to have symptoms again. So we watch to see, and sometimes people can have very small changes in their myeloma that are very subtle relapses, where the protein is just going up real slow, and we can continue to watch it. But then if it begins to build up steam, then it looks like it's inevitable that they're going to develop symptoms again, that we headed off at the pass. So fool me once, shame on you. Fool me twice, shame on me. If the protein level begins to rise, we don't let that just before it begins to cause symptoms, that we intervene to then bring down the disease once again. And that's relapse, as opposed to refractory myeloma. So relapse myeloma means that the disease comes back, and we treat it again, and the disease goes down. Refractory myeloma is a bit different, and after someone has had the disease for a long time, that one thing that could happen is that the disease could come back, and it can be more difficult to treat, where it doesn't go down quite as much, and then you try new therapies to try and get it under control. And one of the most active areas of research is treating refractory and relapsed myeloma.
Other questions?
Yeah, I just wondered, are there any ethnic or lifestyle factors that make one more susceptible to multiple myeloma?
So, yes. So the incidence of myeloma in general is 5.6 per 100,000. In the African American population, the incidence is double that. So the incidence is 12 per 100,000. And why is the disease occur higher? Why is the incidence higher in African Americans is truly unknown. But I think that we're getting close to the discovery point of that. It's not related to diet. It's not related to weight. It's not related. The ethnicity difference is probably something that is deeply genetic. On the other hand, people of Inuit or Asian descent actually have a lower incidence of myeloma. So there is and people of Hispanic and Middle Eastern descent kind of have the same incidence of myeloma that Caucasians have. So one thing that we know and still don't quite understand is why people of ethnicity have a higher incidence of myeloma. Also, the incidence increases with age. So as people get older, the likelihood of them having myeloma gets higher. And it's likely because Is there one factor that causes myeloma? There isn't any one factor that we know that causes myeloma. It's a disease that is accumulated over age. So you get exposed to toxins, infections, and finally those plasma cells have a mutation that then causes the disease.
Other questions? I'll ask a question. The audience?
I'm not sure exactly how to phrase this, but you mentioned at the beginning that there's all these new drugs out and people are living with this longer and longer, and I just wondered if there's a general way to tell us what you're most excited about. I mean, you've talked a little bit already, but some of the drugs or some way just, giving hope to patients.
Why don't we, last one, each of you give me what you think your the newest drug or the hottest drug or the drug you're most excited about. Monoclonal antibody.
So to me, but that's because of what I do research on, is the checkpoint inhibitors, like PD-1, the medications that enhance the immune system to kill your myeloma. But what I'm most excited about is the combination therapy, is that myeloma has actually brought us, transplant and non-transplant, has forced us, non-transplant and transplant physicians together. We can't work without each other. And that's because we have to offer you with this, so many treatments, we have to offer you continuity of care. So now patients more and more are treated in myeloma programs where they get their medications before transplant, during transplant, after transplant. But I think that all of these medications that we're going to talk about, monoclonal antibodies, checkpoint inhibitors, are best used in a team, in combination.
Completely agree with what both of you said. I think immunotherapies in general are really coming on fast, and both classes of drugs are among the most exciting things happening in cancer therapy in general right now. There's also been work in myeloma and other blood cancers, modified T cells, CAR T cells. Yeah, Utah's doing that. There's other ways to modify and target T cells. We've done some work. I think Larry Lum is somewhere in the back, at Carmanos, who heads our immunotherapeutics group. I think at a lot of centers, there's a lot of energy and focus right now on these immune-based therapies, cellular and immune-based therapies.
So I'm going to sound real corny, which wouldn't be new. But I think one of the things I'm most excited about is the people who are now involved in myeloma. It is unbelievable. Again, when I was a resident, I went to the American Society of Hematology meeting and went to the myeloma section. And I don't know if this was maybe pre-MMRF, there was Dr. Bartologhi and Dr. Anderson, and there was me. And I walked in, I was like, Dr. Where are all the myeloma doctors? And they were like, this is it. And I said, okay, guys are nice. And then I kind of walked away. When people would present research, it was these super small rooms, and there may have been like a few people in the audience involved in myeloma research, 15 years ago. Now, at the last American Society of Hematology meeting, they have these near arenas that are full of people who are doing myeloma research. And Jeff and I walked in to one of the sessions, and there was no room. And I'm like, they should have a seat reserved for me, because I was there when none of you guys. And so we went out the hallway, and in the hallway, that was all taken up, and then we went into it was in the middle of the floor, in the middle of the hall. They put up a screen and a speaker, because there were so many people interested in myeloma. And then when we sat down, I was like, who's taking my seat? And there's all these people with long hair and wearing blue jeans, And I was like, all these young people are now involved in myeloma research when there used to be nobody. And everyone is focused and excited. And so I think that, and I was thinking about this last night, there is, the thing I'm most excited about is becoming old as we speak. Because there is some 18-year-old with a ponytail, working Birkenstocks, and probably hasn't bathed in a couple days, who has an idea that's going to be a paradigm shift for this disease. And that's what I'm excited about, the people. I wish I could have my seat back, but I'm really excited about it.
Can I just add to, so in terms of excitement, I agree. Immune therapy is just really become a renaissance. And I do think, I just attended an immune therapy conference in New York, a fairly large one, and they are working in other diseases such as melanoma, such as lung cancer. And I think what the myeloma doctors are saying are we're going to have to figure out how to wake up the cells in the bone marrow around the tumor cells, so it'll take combination approaches with many of these agents, but I think it's really encouraging. The other class that I'm going to mention is based on what I described before, that the myeloma tumor cells have different genomic alterations. And in other cancers, they've identified drugs that actually target those genomic alterations. One of the most familiar is a protein called BRAF that becomes mutated in melanoma, and there are drugs that target that BRAF mutated melanoma. Well, in our first genomics initiative, we identified that about 5 to 8% of myeloma patients have this same BRAF mutation. And we said, let's take advantage of the fact that this drug against this mutation is working in another cancer and begin to test it in myeloma. And sure enough, clinical trials testing these drugs against this particular mutation are showing very encouraging results. About 50% of myeloma patients have these, what we call actionable mutations where there are drugs out there that can target those mutations. And we are working with other drug companies to find drugs against those other mutations and begin to test it in myeloma patients. So I think that's another aspect, the immunotherapy aspect, as well as the molecularly targeted drugs that target specific genomic alterations in a myeloma cell are really, really exciting right now, and combined will really help make a difference for myeloma patients.
So for me, it's really the ability for combinations. When we started out with treating myeloma, we had 2 or 3 drugs. So you could mix A with B and B with C and A with C, and you were limited. Then when you got drug D, now you had all those same combinations and you can match. Well, the number of drugs that continue to come out for myeloma year after year continues to grow, which means there's more and more combinations of drugs that we can use. And as we put these drugs together in combinations, almost uniformly, you put 2 drugs together and they're better than 1. You put 1 drug that wasn't working so well, you add another drug to it, and suddenly that drug starts to work again. So as we get more and more tools in our tool belt and more weapons against the disease, it becomes easier and easier to treat patients, and patients continue to live longer. And if you look, not in an individual randomized trial or an individual study, but if you look across the spectrum of people with myeloma, people are living a lot longer and living a lot better quality of life, because if you fail combination A and B, and you go to B and C or D and E, and people continue to do well. And that's, to me, what's really exciting. As a group like this that are putting together money and funding for us to do research to bring these things together is why people with myeloma are doing so well. Other questions, please.
Is there a support group in other hospitals?
There are numerous myeloma support groups around the state. There's one of the larger ones is at Gilda, long-standing support group that has had a very committed group of patients. I mean, they meet once a month, and they usually have anywhere between 30 and 60 attendees a month. But there's groups in Flint, there's groups in Ypsilanti, I'm not sure, there's the Lake House on the east side. There's
I think through the Gilda's Club, the Cancer Support Community, and the International Myeloma Foundation, the IMF, there are several support groups, and the MMRF also supports patient education forums that definitely have spoken at. And so there are a number of fantastic opportunities for patient support and education. I mean, beyond Dr. Google, who is not very knowledgeable about, is very knowledgeable of everything, but not anything specific. I love the new Multiple Myeloma Research Foundation website and information that they give on patients. The Leukemia Lymphoma Society has great information, the IMF has great information, and the Cancer Support Community Guilds Club all have really, really good information for patients.
In the back?
You mentioned that people with smoldering, there is a subset that, if I understood correctly, should be treated. What are the characteristics for that subset?
So, one thing that has happened is that we used to use this 147-year-old test called the urine protein analysis, and where it measured the amount of plasma cells in the urine. And we've been doing that for 147 years. About 10 years ago, patients said, look, we've had enough of collecting our urine for 24 hours. How about we have a new test, a blood test, that can measure these light chains, these particles of the antibodies being put out by the plasma cell. And the serum-free light chain test came to be, which measured the same light chains found in the urine in a 147-year-old test. You can measure it in the serum, in the bloodstream, without having to collect your urine. The one nifty thing that happened is that it used to be a test of convenience, so it kept people from having to collect their urine. But it actually gave us an insight into the biology of myeloma, that when myeloma cells produce these little fragments of antibody, instead of putting together a whole antibody, that it has a different biology. And so this free serum light chain test, when that is very elevated, and when it suppresses the normal immune system, when people have a ratio between the normal light chains and the abnormal light chains, and that's a sign that the disease could behave badly. And that was one of the signs of ultra-high risk myeloma. In addition to having using the x-rays that we used to use, the standard skeletal survey, that is a 115-year-old test. The first x-rays done for myeloma were done in 1901. And so that's an old test. And so what we've done is we've done PET scans which can identify metabolically active areas in the bone, MRIs that can get very high resolution lesions in the bone, and CT scans. And we find that there are lots of these little lesions that wouldn't be picked up on a 115-year-old test, that's a sign of someone that could progress into symptomatic myeloma. And the last feature of the ultra-high risk patient, so one is the light chain ratio, the other is the high-resolution x-rays, and the third is that if there are lots and lots of plasma cells in the bone marrow. So to get a diagnosis of myeloma, you need more than 10%. So there's some patients that have 11% plasma cells in the bone marrow, and those are smoldering patients. If you have 60% plasma cells, more than 60% plasma cells in the bone marrow, then that is another sign that symptoms could come about in the next few years, and those are the patients that have the ultra high risk, that have been, before we used to just watch them as we watch the other smoldering patients, now they've been incorporated into the ultra high risk group that the recommendation is to consider treatment for.
And I think, so that's sort of the official list of things that have been added. And I think the other group of patients that we all see and think about are patients who may not meet those criteria, but if their M protein is rapidly accelerating, it's not an M protein that's just sitting there over time. It's an M protein that's doubling every few months. You know that that's a patient whose disease biology is different than the average smoldering patient, and we may pull that patient into treatment before. That's the patient who you've met the day before they become symptomatic, probably, right?